Good evening all and welcome to another session of FCPM. Today we have an eminent faculty, Dr. Seema Rao, who is an Associate Director of Karnataka Institute of Palliative Care Education and Research, Bangalore Hospice Trust, Karnataka. She is an experienced psychiatrist and palliative medicine specialist with a keen interest in geriatrics and palliative care. Skilled in psychotherapy for end-of-life issues like dignity therapy, spiritual care, research, mental health counseling, and pain management. She was the organizing secretary of 13th International Conference of Indian Association of Palliative Care, IAPCon 2023, and was part of the team that organized the 2.5-day conference at Newhan's Conference Center, Bangalore. We are happy to have you for the day, ma'am, and over to you.
Thank you so much. You will have to enable screen sharing for me. Is to share my PPT, please.
Yes, ma'am. You have been made to co-host.
Yeah. Okay. Now, yeah,
please
yeah.
start sharing.
Yeah, I can now. Yeah. Thank you. Good evening, everyone, and thank you for this opportunity to talk about communication skills, primarily collusion and breaking bad news. So I mean, if it is possible, just please put on your videos so that it becomes a little bit more interactive. So to start with, is communication with seriously ill difficult? I would like to ask you the question. Do you think it is very difficult? You can put it up in the chat. Yes.
Yes, it's very difficult.
It is very difficult. What makes it very difficult? What is it that you find very difficult about, communicating with people who are seriously, okay, I'm getting a lot of chat replies. Okay. Is any specific things that you find very difficult? Or let me give you an example, okay? So we had this 38-year-old lady, Geeta. She was divorcee. She was admitted in our hospice about a week back. She was staying with her mother and her niece, and she had CA colon. And about 14 years ago, she was treated for it and she was completely disease-free. She hadn't told her husband about this illness. And when he came to know about it, he abandoned her and subsequently they have divorced. Now for the last 7 years, they've had a non-healing ulcer. She's had a non-healing ulcer in her anal region. Had been repeatedly investigated and treated for the same with no improvement. And the family did not tell the treating doctor that she had a diagnosis of cancer 14 years ago. They had never mentioned it to the local doctor whom they were consulting. Now, after repeated treatment, when there was no response, the doctor advised her to have a biopsy. And she was diagnosed with, it was rectal cancer, CA rectum. She now has a huge wound in her anal region, and it's definitely not going to heal. Recently, in the COVID, she had lost her father, who was a major, support. Her support system was primarily her father during the initial illness, and her elder sister died of jaundice about 7 months ago. Now you have only the mother and the niece who are looking after her. They have told her that once the wound heals, she knows the diagnosis, but what the doctors have, the mother has told her that once the wound heals, the oncologist will start treatment for the cancer. She has come to the hospice. She got admitted here with the expectations that we are going to treat and heal that rectal wound. And every day she would ask the doctor, when is the wound going to heal? And she was getting very impatient because she was, that it was not healing and she was not getting well. So what is it that you see here? You can unmute and speak also, no issues. What is it that you're seeing here?
Good evening, ma'am. I'm Dr. Roja.
Pardon?
I am Dr. Roja Ramani from AP, ma'am.
Yeah.
Madam, as for the scenario, what the thing is when you are why you are feeling so bad to reveal the diseases. Already she underwent some treatment. She thought that she is recovered completely. Now again, recurrence of the disease when you reveal the diagnosis as a cancer, as a malignancy, the total family who is already supportless because of loss of father, all those things, they are again upset. That's why when you are dealing with this patient and breaking the bad news, it is difficult to
Yeah.
sudden.
So suddenly now here is a patient who has come thinking that things are going to get better because she is already 14 years back, she has been treated for the cancer. She has come with the expectation that things are going to get better. What she doesn't know is the fact that, that this disease is not going to, this wound is not going to heal. And so chemotherapy is not an option. She has reached a stage where it is not curative, right? Now, but the family has not disclosed this to her, right? So what is collusion? What you see here is collusion, right? What is collusion? Any idea?
Recurrence, again facing same problem.
No, collusion is where the family doesn't want us to hide the diagnosis from the patient.
Yes. Yeah, it is a secret or an implied understanding between, it could be between the clinician and the patient, it could be between the clinician and the family member, or it could be between the patient and the family member to withhold either complete or partial information about a serious life-limiting illness, right? You understood? So it is like, it's a secrecy. It is a secret plot, right? It's a conspiracy of silence, as we call it. Okay. This collusion can be between the clinician and the patient or the family member, or it could be between the family members not revealing everything to the doctor. Now, in this previous case scenario, where all do you find collusion?
Initially, collusion is when she kept it away from her. She didn't say about to her husband.
Absolutely correct. Second
is when now
is
the
when the
family
family
told
pardon?
the family has told her.
The treating doctor about the diagnosis of cancer 14 years ago, ma'am.
14 years ago. Then the third
Third is the family which told the doctor not to tell the patient anything.
about the current
Current,
incurable
yeah.
disease, isn't it? So you can see the collusion is not only between the doctor and the patient or the doctor and the family caregiver. Sometimes collusion occur within the families. Two people will collude and the third relative or family member will not know about the disease. Or it could be between two family members who collude and not reveal the whole thing to the doctor, right? So there are three places where you have seen collusion here, right? And collusion generally occurs like, is influenced by the culture, by the family dynamics, the age, gender, the socioeconomic status, the emotional vulnerabilities of the patients. It all depends upon that. In the West, it is the ethical as well as legal duty of the doctor to disclose the diagnosis and prognosis to the patient and only to the patient. Unfortunately, in India, we do not have such rules. So it's a ethical responsibility, but it is not legally binding. And in India, how many, most of the time when we talk, the family members come first and they will tell us, don't tell the patient about anything, isn't it? They will, when you enter a sick patient's ward, most of the time, the family members will stop the doctor from having a direct conversation with the patient and the relatives would talk, right? So why does this collusion occur? A study was done in one of the countries, and what they found was one of the most important reason is it's why collusion occurs is because the family members want to protect the patient. Okay, they fear that the patient may lose hope. Sometimes the family is not willing or family is in denial. They are not willing to accept the diagnosis or the prognosis. At that time, when family members themselves are in denial, it's very difficult for them to convey this to and have this open discussion with the patient. Sometimes it's lack of information. Sometimes it's the thought that the patient, if we tell them the truth, they will become sad and depressed. They will want to kill themselves. They will lose hope. They will stop eating and drinking. They will be angry. Basically it is to protect their loved one from the impact of what this sad news is going to bring in. So that is why the underlying reason for collusion is that. So what do you think? Is collusion beneficial or detrimental?
Ma'am, it may seem beneficial to the family from their perspective, but in the whole picture, it's detrimental because it doesn't change the outcome in any way per se.
It
Yes.
raises false hopes. That is why a bit.
It raises false hope. So it could be detrimental most of the time.
Yeah.
But also we have to keep in mind that sometimes, right, so there might be circumstances where the patient may not want to know. So it could be, beneficial.
Beneficial.
We'll discuss.
Beneficial.
Yeah. Then who are we protecting? Are we protecting the patient, the family member, taking a class? I'm taking a class. I'll talk to you later. Okay. So whom are we protecting? Are we protecting the patient? Are we protecting the family member or the clinician? Right? That's something sometimes we ourselves are very uncomfortable about talking all this about death, dying, incurability to the patient. So we don't want to talk about it. Right? We want to focus on the recovery plot. Right? We will talk about further treatment options, further chemotherapy, what could be done, what can be done, rather than talking about, incurability. And sometimes the patients and the family members also don't want to hear that we are not able to treat the disease, this treatment is not possible, cancer has spread. They don't want to hear the news. So it works both ways. For the clinician who's uncomfortable and who wants to keep on talking about recovery, and for the family members and the patient who also don't want to think about, who are looking at the short term. Okay, this treatment is not working. What other treatment can we go through? So, you're focused on the plot of treating and treating and treating rather than talking about incurability, death, dying, and the other end of life trajectory. So all collude together. Sometimes the patient, the family members, and the discomfort of the clinician to talk about death and dying, and the patient and the family members to hear about death and dying. All these sort of contribute to the existence of collusion. What is the cost of collusion? Okay, so what happens to the patient when the disease is not going to improve? For Geeta, when a wound is not going to heal, she's going to lose trust, right? Trust towards the doctors as well as towards the family members, because both the family member has actively, her mother and niece have actively told her, once this is cured, you can go for chemotherapy. So when this is not getting cured, she's going to doubt the doctors, she's going to be angry, she's going to insist on the family shifting her to a better hospital so that this wound can be cured. The family is not going to shift because they know she's nearing end of life. So that will create a lot of friction there, right? And we lose a lot of opportunities to, there would be some unfinished business. I'm sure we will be having an end of life care class where we talk about how we, peaceful, good death. What are the components of good death, right? So we lose an opportunity on talking to the patient about, their unfinished businesses. And since they don't know the prognosis, they can't make any decisions for themselves. So self-determination is lost. There is fear, there is suspicion, and there is anger. This happens to the patient. For the family member, they have to bear the burden of deception. They should be very careful all the time, tense about not talking about this, about, keeping up the deception. They have to protect the family members of hearing it from others. Like, for example, you bring a patient to a hospice where 70% of the patients know they are end of life, that, oncological treatment is not happening. Somebody the other may blurt out the prognosis here to the patient, isn't it? So they are part of this deception. So there's a lot of guilt, there is avoidance behavior. So when the patient starts asking more and more questions, what do the family members do? They block that communication and they start avoiding the patient. And lack of planning for end of life care, because neither the relative nor the patient is willing to talk about it. So which can make the end of life care very stressful. Or for all three, for the patient, the caregiver, as well as for the healthcare provider. And there is a breakdown for us. What it happens is there is lack of compliance with treatment, breakdown of the relationship that we have with the patient. Patient is not going to trust you or not going to be satisfied with the service. So in a way, we pay a high cost for propagating the collusion. So we have to be very mindful about this. So what do patients actually want? This was a study done in 2019 at Tata Memorial Hospital. They asked patients, what do they actually want? What came out of the study is patients with cancer preferred full disclosure of their diagnosis and prognosis. But whereas the family caregivers preferred non-disclosure of the same to the patient. So patients wanted to know, but the family caregivers did not want patients to know. And why did patients want to know? Patients felt that knowing the diagnosis and prognosis helped them to prepare. It gave them they felt more in control of the decisions about treatment that they were able to take. They could understand the complications better, and they were able to plan well for the future of their family and for themselves when they knew exactly what was happening to them. So this is a recent study, and this is something we should keep in the back of our mind when we talk to patients about have these conversations with the patients. And also it is important to look at the ethical perspectives of all this, right? See, as I said before, in this study, nearly 80% of the patients wanted to know about their diagnosis and prognosis. But there is 20% who did not want to know. Okay, so does the end justify the means? Okay, so one thing that we have to look at is, you cannot apply blanketly that we have to tell all patients, right, the truth. Okay, it also depends upon whether the patient wants to know the truth or not, wants full disclosure or not. Okay, there were some patients, some of the patients, there was one gentleman who had come who had leukemia, and he would come for transfusions every month. He would come for transfusion, and one of the time, as we were evaluating him, I would ask him, do you want to know the details about your illness? What was happening to you? Would you like to know? He said, no, humse kuch mat batao. That is, don't tell me anything, because I get very tense. Whatever it is, you talk to my son. So it was about 3 months. He came, 3 to 4 months. He came every month for transfusion without discussing about what his disease was and what he wanted to know. And then the frequency went up to every 15 days, right? Again, at every visit, we would ask him the question about whether he would like to know about his diagnosis and prognosis, and he would say no. Once his frequency of transfusion started increasing, every 15 days he would come in, he started becoming weaker and weaker. One day he himself came with the request that this doesn't seem like it is improving, right? I'm getting weaker and weaker. The blood is not staying in my body. I'm coming every 15 days. What is this disease? I would like to know about it. So at that point, he was prepared to receive more information. So that was then when we sat down and had this discussion about what his disease was and what his prognosis was. So, so the absolute rule of being truthful, regardless of the consequences, does not apply. Now, who decides the patient's best interest? Do we decide? Does the family caregiver decide? Or is it the patient himself who sort of decides? That's something we have to keep in mind. And how do you achieve the balance between beneficence, non-maleficence, and justice? So keeping these ethical perspectives in mind, keeping the cultural and the context in mind, we may need to proceed. There are times when we are stuck because some of the patients come from very rural backgrounds where the head of the family takes all decisions. And we've been repeatedly told in such families that the patient does not. If the patient is a woman, the jitani, what we call the jet, the husband's elder brother takes the decision, and they won't even allow patients to come and have these conversations. So this is very culture specific, and we have to, keep all this in mind before we go ahead and handle pollution. Then the legal perspective comes in. Can a doctor withhold information from the patient? Yes or no?
No, ma'am, we cannot
Yeah.
withhold.
Yeah.
No, we
You know?
can't.
Yeah. But what if the patient does not want to know? Then are
So
you
we will,
bound to
we
tell?
will just keep saying the patient, like you told the example, ma'am, that every time the patient come, we may offer
Yes.
him a chance that we want to explain. Do you want to know about your diagnosis? Every time he'll come, and
Yes.
maybe one day he's ready. And
Yes, ready for it. Absolutely. So if the patient does not want to know, we respect. Somebody has written in the chat, we respect the patient's choices at that point in time, but also keep inquiring at every point whether they really want to know or do not want to know. Absolutely. The basic principle for managing, managing collusion is two. One is respecting the patient's right to know. If the patient asks you a direct question, it is important for you to tell the family caregiver, even if you don't want to know, if the patient asks me directly, I have an obligation to tell the patient the truth. I cannot lie, right? Or I cannot withhold information. At the same time, it's also important to validate the feelings and the motivation of the family. See, they are doing this out of love, out of some misconceptions probably that they have, that telling the diagnosis is going to cause more distress. Absolutely. Distress will be there. So we need to reassure the families that it's not going to cause major harm, but some amount of distress will be there. And we also have to teach them and empower them on how to manage this distress. So when we talk about handling pollution, that is what we call a friends approach. I think palliative care is very, we have a lot of acronyms coming in, right? Mnemonics coming in to help you remember the steps, right? The first in the friends approach is acknowledging the feelings of the family. Okay, so I will give you example of how we managed Geeta. The second one is finding out what is the reason for the collusion. What is this caregivers frightened of? Why are they not telling the truth? Is it because they themselves don't know the prognosis, right? Or is it because of some misconception that they have? If they don't know the prognosis themselves, obviously it appears like collusion, but it is lack of information. So then we provide the information and tell them. But if it is because of some misconception, like patient will die, patient may commit suicide, patient may not comply with treatment, then we have to reassure them. And we have to identify with the intention of the family member and reassure them that you are on the same page as them. You also want to protect the patient, but protect the patient from the distress that comes out of not telling the truth to the patient, and explain to them what are the pitfalls of escaping from talking to the patient about this, the truth, right? What will you do when she deteriorates, when she starts asking more and more questions? What are you going to do? Discuss about what the patient's feelings would be when they deteriorate, the lack of trust that can come in, the anger that come in, the damage that can occur, the unfinished businesses. If she has to say something important to her family members, she is not given an opportunity to say that, right? And in this process, stabilize the family dynamics and negotiate on how you can go ahead with this. So now what happens when we talked about acknowledging, what we did first was sit with Geeta's mother and acknowledge her feelings. I can see that this has been very difficult for you. You have already lost one daughter. You have lost your husband, and this is a second daughter that you're going to lose. I think this must be, it is a very scary situation for any mother, isn't it? like, and only what she has left as a granddaughter. So acknowledging how terrible this has been for her. And, as I understand, you've not told Geeta that her disease was incurable. Can you tell me, what are you worried about? What are you scared about telling her? So what did she say? She's been extremely anxious since the diagnosis of this disease. She's been irritable. I'm scared if I tell her, she might become more angry or she might collapse and she may not be able to tolerate this. So what makes you think that way? That was the next question. Why did you feel that she may not be able to tolerate it? Is there any specific reasons? So she said, no particular reason, but I thought that, she may not be able to tolerate it. So then you move on to the next aspect of, previously, right? When she has had, there has been multiple deaths in the family, she has had cancer before. How had she handled all this? This is to gain an understanding about the psychological processes of this individual, the landscape of this individual. Now, suppose she had said last time when we gave her the diagnosis, she went and attempted suicide. Had she said that, would you still go ahead and tell the truth?
No, ma'am, we will not say.
You would be more
Careful.
You would still push towards telling the truth, but you would, want to collect more information, understand, and maybe get a, go a little more slowly, isn't it? But here, fortunately, she said she's very strong. She took it very well. Even when her sister died, the father died, she was a very strong individual. So then the intention, you validating the intention, I can see that you want to protect Geeta from further pain. We respect that. We also share your desire to save Geeta from greater distress. Now, with the wound not going to heal, she is going to keep asking us. And if we don't give her an answer, a truthful answer, she is not going to trust us either. Right? Taking the conversations about sharing a commonality. You're on the same side as the mother, but at the same time, you want to do it a little bit differently. That is what you're going to speak about it. And the pitfalls of escaping. She continuously asks us about the wound. She is also angry that we are not doing enough. How is all this affecting you? Understanding the mother's emotion. Mother says, as usual, a lot of guilt and regret comes out, right? I'm spending less time with her now to avoid answering because she gets very angry with me. I'm going to move away. And then discuss the pros and cons of not telling. By not telling her, you are unable to spend those last moments with her. You are running away from her. She's also angry all the time at the doctors, at the family as well. And discuss the pros and cons. And also at the same time, ask them, how did you feel when you first heard the news? Right? So the mother says, I was devastated. Right? I couldn't think straight. I was shocked. Now, how is it that you feel now? Now I'm a little bit more stable, right? I'm able to accept it and I'm able to plan ahead and think. I'm also distraught, but at the same time, I'm able to deal with it. So say that Geeta will also go through the same thing. Initially, when you tell her, she will be distressed. And if we give her the adequate support, you give her the adequate support from your side, we give it from our side, we will be able to help her deal with this situation and we will be able to move ahead. So stabilize the dynamics, negotiate and reassure. Okay, can I ask Geeta what she thinks about her current situation and whether she wants to know? Can we initiate this dialogue with her? We can then plan to tell her slowly, and our team will be there to help both of you deal with the outcome of all this. So, you can negotiate and plan. And remember, this does not happen in one sitting. It takes repeated interviews, it takes repeated consultations to understand what the mother is going through. And then once you have the mother on your side, you can go ahead, discussing this with the patient. So this is the algorithm about, how you can proceed, what I told you. And first of all, one of the most important things to do is to ensure that the family is fully aware of the diagnosis as well as the prognosis. Sometimes it's easier to give a small pamphlet about what solutions can do to explain of the pitfalls of not telling. And also it's important to reassure them when you break the bad news, it is done in a very systematic manner. And, we will take care of the emotional distress that comes out of telling her. Sometimes family members feel very distressed and they are not able to tell the news. In that case, you offer to tell, start this conversation with her. And also, make them understand there is going to be distress, there's going to be anger, there is going to be bargaining. So what are all the processes that that person goes through, and how the support systems which are in place from family, from the healthcare system can help her. And reassure the family members that you will be there to sort of, support her through through this process. As healthcare providers, you need to have some strategies, right? You need to know what, and understand how to address this. You have to have the competency to address these issues. If there is so much of distress, you need to have people who are equipped to handle the distress as well. And it's also important to routinely assess for collusion in palliative care. And you need to be trained in difficult communication, how to break bad news, how to handle collusion, how to handle denial, right? This lecture may not be sufficient. There should be role plays where you can deal with these things. And also developing a protocol to address collusion. How do you go to within the system, within your organization, and how to resolve conflicts around disclosure. So you need to have specific training for that, as well as a protocol in your organization. And finally, to do or not to do depends upon your decision making, will depend upon evidence, right? What is the evidence for breaking collusion? What is the benefit? What is the harm? What is the patient and family preferences? Is it fair to do it? Is it going to impact the quality of life? And what are the contextual factors like legal, training, the comfort, so, we have this Johnson's 4-box model where you will put in these things and finally make a decision of to tell or not to tell. So the blanket rule that you have to be truthful. It's your ethical responsibility, but also remember 20% of the patients do not want to know. So we have to keep that in mind and approach it in a very systematic, structured manner. What happened to Geeta? 5 days into the admission, she started getting angry and upset with the medical team. Finally, her mother agreed that we have to tell her the truth about the disease. The medical team worked to break the collusion and inform Geeta the truth about her disease. The session for breaking the bad news to her was scheduled, with her mother being part of the conversation. Now, how we did that, I will, what happened, what are the breaking bad news, I will tell you next. So I will stop for a second here. And if there are any questions, I will handle this for a short period of time. And then we will go on to the next section of breaking bad news.
Ma'am, I want to ask a question.
Yeah.
The other day I had gone for a home visit to see a patient, and he was in a very bad condition with skeletal mats all over. But the patient seemed to, there was collusion because the family members, he knew that he had cancer, but he did not know the prognosis. He thought that he would be getting better. And that's what he kept on telling us. So the family members, they told us that he was being treated in a cancer hospital where the doctors had initially told them that the patient should know. But later on, the doctors told them that since he was now in a very bad condition and end of life, so there is no point in telling him. That's what the oncologist had told the family members. So they told me that, then ma'am, what's the point of telling him now? So I told them that even if that's the situation, the patient has a right to know, and you should tell him. And if you cannot do it, we will help you out. So, I mean, if another doctor tells this to the family members, then how to go about it?
Best thing is to ask, whether the patient wants to know or not. At some point or the other, patient, it's better to inquire whether he wants to know or not. I think finally we will be guided by what the patient wants, isn't it?
No, they didn't want us to talk to the patient about the prognosis because they said that the doctors had told us that he does not have much time. So why to increase his distress and tell him? That's what the doctors had told him. So
So there is no one specific answer to that. It depends upon probably, obviously, when a doctor has said, and that to a treating doctor whom they place so much trust on,
yeah.
that it will be difficult to counter it. But at the same time, it would be interesting to ask them leading question. Has he asked about what is happening to him? Right? At any point in the conversations, has he asked you about what is happening to them? To him, okay? Does he get angry that he is not getting well despite so much of medications? So you can ask these pointed questions, and if they say yes, he was getting angry, you could say, huh, that is one of the things when you don't know that uncertainty, when he doesn't know, there are times that he can get angry, he may feel upset. We are also robbing him of the opportunity of planning his life, in case, these things you can sort of answer him.
No,
Lead.
I mean, what I wanted to know was, can this be a reason for not telling the patient that since he doesn't have much time, so there's no point in increasing his distress?
Now, suppose I see a patient whom I think is imminently dying in the next 24 to 48 hours, right? Correct?
Yeah. Yes.
Patient is extremely breathless, okay? Or in excruciating, intractable pain, or is it delirium? Would I go ahead and tell the bad news?
No, in that case, maybe not.
Yeah. So it depends upon, I said it's contextual, isn't it? We have to look at the context, right? Does telling the news, does the patient want to know how much of the impact it will have? See, even in a bedridden patient, if the competency is there, okay, there could be things, unfinished businesses that person would want to do, some good advice the person may want to say, right? So it's always a good practice to try to talk to the family members about what telling the truth will achieve. What end of life care planning will be more systematic if the patient knows where they are in the illness trajectory and what is happening to them. So it's worthwhile having the conversation with the family members. And if the patient has the competency and is stable enough to be told the news, I think it is important to, break the collusion and talk to them.
Okay, thank you, ma'am.
Yeah. I'll take Dr. Das. I'll take your question in the end.
Thing is that generally for the adherence to any treatment program
Yeah.
of cancer patient or any other cases, I think the collusion issue needs to be resolved first.
Compliance will be better in that.
And
yes.
that is the reason why we can see a patient can adhere to the treatment all throughout the program itself.
Correct.
And second thing, I once again repeat. Can you repeat once again the FAN approach for the?
I'll sort of at the end of it, I will sort of recap everything. I'll tell you again.
Right.
So now I'll go to breaking bad news, that one more section, and Sheila and the rest of them, we can take the questions later. Yeah, at the end of it, right? So when we come to now, we had what the job in our hand was to break this news to Geeta. Okay, so now coming to what is bad news. Bad news is any information that drastically and unpleasantly alters the patient's view of his or her future, right? So it could be telling about, it's an unpleasant experience, isn't it? Both to the healthcare provider as well as to the patient. It's basically a very, it's not a very pleasant experience. And that is the reason why we hesitate to have these conversations, isn't it? And remember, the moment you give a person a bad news, you're going to be part of their lives forever. Either they will hate you forever or they will remember you with a lot of gratitude. So if you do it right, they will remember you forever positively. If you do it wrong, they will forever hate you. And you have only one chance to get it right. So you have to be very mindful of how you talk to the patients. It's a very complex communication task. There is a verbal component to it. There is a non-verbal component to it. You have to respond to the emotions of that patient who's sitting across with you. You have to deal with the stress that, everybody wants to be told that they're getting well, they're going to get cured, isn't it? When you have to deal with that loss of that hope and expectations. You have to deal with the family members who are there, and you should be able to give hope, realistic hope, even when the situation is very bleak. So, you have to have the competency to do all this. And studies have shown that patients generally desire full disclosure. They need to know. It reduces the uncertainty. They are able to plan for the future, right? And they are able to grieve. If we keep telling them the truth, right? By the time they are dying, they reach a level of acceptance. They are able to grieve, go through that grief process and reach acceptance. And they're able to adjust, that they won't have any unrealistic expectations like Geeta was having of the wound healing in when they know the truth about what it is, which means that we can shift focus on talking about treatments to quality of life, to leaving behind a legacy, to life review, to dignity, to having a dignified death, to talking about the preferred place of care, preferred place of death, where they would like to die, what is it that they want to do before they die, what are the rituals that need to be conducted. So there are a lot of things that we do in end of life. So if we don't tell them about the prognosis, we'll never reach into those, and and good death may not be possible. So that is why we need to have full disclosure and learn the capacity on having these conversations. Okay, some situations where we sort of break bad news is when there is the first is when at the diagnosis of a life-threatening illness, when there are degenerative conditions settling in, when the disease has recurred, when children have developmental disorders, right? We have to tell the parents about it. When there are irreversible side effects, you cannot progression of disease or failure of treatment, when the change in goals of care from curative to control to palliative, and when we talk about do not resuscitate, right? End of life care. These are all situations in the trajectory of the illness when every time we have to keep talking about bad news to the patient. So you are with Geeta. She asks you again, doctor, the oncologist has told me that once the wound heals, we can proceed with chemotherapy. It's been almost 5 days now. Will this wound heal completely? Okay, this is the question that she asked. So now I'm going to put some answers to you. You have to tell me which one of it you choose, or what is it you would say. Don't worry, it's going to be all right. Would you do that? No, very good. It will get better with time.
No.
No.
Okay, we are doing everything we can. It could have been worse, but we are doing everything we can. Would you do that? Say that? No, no,
Yes.
very good.
No, no.
Say that? Okay. Somebody said yes. Okay, then you would say we should be able to face whatever comes in life. Everyone has their load of suffering. You need to be positive.
Yes.
Yes. Okay, it will be better if I discuss this with your mother. Okay, no, no. Okay, by the way, I hope your pain is under control.
No.
Yes.
Yes. Okay, just pat her on her head, hold her hand, nod, and just console her and walk away.
No.
No. Okay. So these are all pitfalls that we have to avoid. None of this you do. Okay. This was a googly. Okay. Right. When you say don't worry, it's going to be all right. It's, you're blocking her. Okay. You're pacifying her prematurely. It will get better with time. False reassurance. It's not going to get better with time. We are doing everything we can. It could have been worse. What are we doing? We are minimizing the issue, right? It doesn't matter. It could have been worse for someone else, but this is worse enough for me, right? We should be able to face whatever comes in life. No, that's advice. You're not supposed to be doing it. It will be better if we discuss with your mother. You're shutting down her talking. Like, I don't want to talk to you. I'm going to talk to your mother, right? By the way, I hope your pain is under control. You're deflecting it to physical issues because you're uncomfortable with dealing with her question. Just pat her on her head, hold her hand, nod and walk away. Again, you're avoiding facing the question that she is looking at you for an answer for, right? So all these are something that we should never do. So next comes, what should we do? That is the most difficult part, isn't it? Okay. So what do clinicians find difficult? They find breaking bad news very difficult, right? Because first, how do you tell a person that that wound is not going to heal? You're going to take away whatever hope that she has, right? How do you use a language that is understandable to the patient, right? So these are things that makes, you know, things very difficult. And one of the things that you have to remember before starting a conversation about bad news is it's a planned event. It's like a surgery. You can't do it on the corridors of the hospital, right? You have to plan for it beforehand. Okay, you have to understand what the patient wants, what are the cultural barriers, the fears, what are the primary caregivers, and you have to include the palliative care team as well. So what happens during breaking bad news? This was a beautiful graph that I found in one of the studies. Both have similar levels of stress when you start your interview, right? The doctor, physician, as well as the patient. And the physician stress goes up and up during as the interview starts. And the poor patient has come unaware, right? As the physician conveys the bad news, the physician's stress starts coming down. Whose stress increases? The patient's stress increases. At the end of the interview, the physician's stress has come down, but the patient's stress is at the peak, right? So we need to be managing the stress of the patient when we say the bad news. So there are many models of breaking bad news. I am going to talk about one model which we normally use called the spikes model, right? So what does spike mean? Spikes mean setting, perception, invitation, knowledge, ability to handle emotions and strategy and summarize. I'll just briefly talk to you one by one about this. When we talk about the setting of the interview, as I told you, it is a planned event, right? You should know about the patient's diagnosis, prognosis, everything from the patient file. There should be a caregiver along with the patient, and you should have a private area where you can, with no interruptions, where you can talk to the patient and involve significant others as appropriate. Sit down, connect with the patient verbally and non-verbally. And you can tell the patient about the agenda. Now, for the next 40 minutes, we are going to have a conversation about your biopsy or about whether your wound is going to heal or not. We will discuss this in the next 40 minutes to an hour. Okay. And when you see the patient for the first time, be mindful that you introduce yourself and call the patient by their name. Introductions are about making that human connection, right? With one human being is suffering and one vulnerable, the other human being is someone who can help their suffering. So, you are not a doctor at a higher level and they are patient. You are two human beings who are having the conversations. So seating yourself at eye level, having an eye contact, and probably not having the desk between the two of you when you have conversation is extremely important so that patient is comfortable and you are also comfortable. Now I'm going to show you picture A and picture B. Which do you think is an ideal way of talking to the patient?
B, ma'am.
Why do you
Picture
think?
B. Picture B.
Eye to eye contact.
Eye contact,
Eye contact.
close.
Yeah.
She's
comfortable.
my concentrating on the patient,
Yes.
looking at the patient.
What is the posture? How are the hands?
Yeah. Picture A,
Close,
picture is
eye level.
and B is close.
relaxed.
Covering.
Good, good. So there is something called as solar. Non-verbal language is extremely important. Okay, that is something called as solar. Face squarely. Be at eye to eye level, no looking down. You know, when we do rounds, patients are lying down and we are standing and talking. Avoid that. If there is a chair, pull out a chair and sit in front of the patient when you talk. Have an open posture, right? Lean forward a little bit when you talk. Maintain eye contact and be relaxed. Don't be very tense. Don't be very defensive, right? Or your hands behind your back or folded in front of you, right? So it's very important to have this body language when you talk, right? Remember, 80% of your communication is verbal or non-verbal?
Non-verbal.
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 Right? That's why I'm asking to see your videos, right? I can see your faces. I can see whether you are interested or whether you are getting bored, right? So
Non-verbal.
I can see all of you smiling, right? So that is the importance of non-verbal communication. You don't have to talk, right? By seeing, you have to be, and remember, pay attention to non-verbal cues. Your patients will tell you a lot non-verbally. So that's extremely important, right? And second is perception. You try to understand what the patient knows about their illness. And for that, you need to ask open-ended questions. What have you been told about your condition so far? What have you been thinking that this test results might show? Is there anything that you're particularly worried about at the moment? Gather the information, explore the perception of the patient of the situation. What are their concerns? What are their expectations? And correct misinformation as necessary. And it helps you to understand, right? When I asked Geeta, okay, is there anything that you're particularly worried at the moment? What do you think she said? She said that if the wound doesn't heal, then there will be no chemotherapy. Am I right? I said, yes. Then, but you know, the wound has become bigger than before. I said, yes. Right? So what is she telling me? She already has a suspicion or already knows about what is happening, right? It's right. So it helps you to understand where this patient is in this journey, right? And I'm going to ask you, I said open-ended question, right? So I've given, I can see from the notes that you have chest pain. Do you still have the pain? Is it open-ended or closed-ended?
Close.
Closed.
Okay,
Closed.
what's a better way of asking this question?
Has the chest pain reduced? Has the chest pain decreased in intensity?
Has the chest pain?
Reduced in intensity, or has it become a little better?
That's a leading question, no?
Yeah.
How are you feeling today?
Yeah.
How is
are you
your
feeling
pain?
now? How is your chest pain?
Yes. How is your chest pain? Can you tell me a little bit more about the chest pain that you are experiencing? Okay. Can you describe that pain? If you ask tight or dull, you have given only two choices. Suppose it's pricking, right? So can you describe that pain? What else did you notice, right? Did it go down the arm, right? What else did you notice? Is it going anywhere else or is it confined to your chest? So, you know, just rather than directive question, asking a little open-ended question. You start with open-ended and as you go, you can be more directive if you want very specific information and listen without interrupting, okay? Actually, statistics show that patients are interrupted 18 seconds. They start talking, you ask a question, the doctor interrupts them in 18 seconds. Okay. Now, setting influences the type of question style. Now, if you're in a busy OPD, you can't be asking open-ended question, right? A patient has come with malaria, you have to ask closed-ended question, directive question, solve the problem, right? I'm talking about terminal illness, breaking bad news, where you use more of open-ended questioning. So where you are will dictate the type of questions that you ask, right? And then active listening. What does active listening entail? It's not only about, you know, the content. You have to listen to the non-verbal feelings of the patient as well, right? Observe the non-verbals and you either reflect back the questions to them, ask for clarifications, sometimes non-verbally nod your head. What do you think it is? You know, sometimes when they are very emotional, leaning forward and touching the patients, and sometimes repeating and summarizing the question. Okay, the patient may talk for maybe 2 to 3 minutes. There might be 3 questions in that. You summarize. As I understand, your concern is, one, the wound is not healing. If the wound doesn't heal, you won't get chemotherapy, and you're worried that our treatment is not helping the wound heal. Is that what you meant? Right? So summarize at the end of it before you proceed. So active listening is extremely important. And then obtaining the patient's invitation. Find out how much the patient wants to know. Is it okay? Do you want to know further about what is happening to you? Okay. Some information may not be very good. Do you still want to proceed? And how much do you want to know? Do you want to know everything, or do you want to know only about whether the wound is going to heal or not? Right? So these are things that you have to gauge, find out how much they want to know before you jump up and tell, right? And then next step is to providing the knowledge. Remember, it's extremely important not to use medical jargon. Okay, I'm sorry. I wish I could give you good news, but the news that I'm going to give you may not be what you are expecting. Do you still want to go ahead and hear the news? That's the first question I asked her, right? I've given her a warning shot, right? That it is not good news. It may be not what she is expecting. Does she still want to go ahead and hear that news? Do you want somebody to be with you when I'm going to talk about it, right? And then break down information into small chunks, right? Don't give the whole information about what is going to happen, how everything. Right now, the wound is not going to heal is all that I'm going to tell her. The wound is not going to heal. So because of that, chemotherapy may not be possible. But what is going to happen next, I'm not going to discuss, isn't it? Because emotions are going to come in. She's going to be very distressed. I need the time to handle the emotion rather than provide information. And at the end of it, it's important to ask whether they've understood what I'm telling, and also use visuals. Sometimes talking doesn't help. It's important to use visuals. And then, as I said, medical jargon is what we are very comfortable in. We have to stop using it. In fact, a simple thing, in one of the patients, when I was working in the ICU, I had told the patient's son that, we will not go for any aggressive interventions, but we will keep him as comfortable as possible. So he said, "Doctor, what do you mean by comfortable? He's suffering so much. What is the comfort that you're going to give him?" Some simple word, a word as simple as comfortable cost, I had to think and tell him, okay, we'll ensure that he doesn't have any pain, that, he doesn't, we will not tie him to the bed. We'll ensure that he's not agitated, that he sleeps in the night. These are the things I had to spell out, right? So it's extremely important to talk in a language that the patient or the family understand. And then what is going to come in? A lot of emotions are going to come in, a lot of anger, sadness, everything is going to come. So how are you going to handle it? One of the commonest technique is nurse. Okay, I told you we are very good at mnemonics, right? You have spikes, you have solar, you have breaks, you have nurse here. Okay, what is it? I can see that you're very distressed. Name the emotion. It sounds like you're very worried. It looks like you're very angry. Naming the emotion. The second step is understanding. I can see that this is extremely difficult for you, right? I understand I can imagine how difficult this is for you. I know that you're worried about whether the treatment is going to work or not. Okay, I know that you're worried that if the wound doesn't heal, you are not going to get you're not going to get chemotherapy. Respecting the emotions. This must be a lot for you to deal with. I'm impressed with how well you have handled this this difficulty. I will be there with you. Whatever happens, our team will be there to support you. So expressing support. And tell me more. What is it that you explore more? What else do you want to know about all this? So, or explore about how else can I help you? I know you're very distressed. Tell me how else can I help you? And maybe holding the patient's hand at that point in time, using silence and touch to, console the patient would be extremely important. Remember, if you don't handle the distress when you break the bad news, then the patient, that would be very harmful to both you as well as to the patient, because you are leaving the patient dangling with no support, right? And then finally, at the end of it, once the distress is gone, patient is able to get some control, then you strategize and summarize, right? You say this today, so today we have discussed this, right? It's important that tomorrow we discuss, maybe in our next meeting, we discuss about how do we go from here. And once you've done done this breaking bad news, it's important to have a very short follow-up to show that you care, and to have the patient come back to you. Fix an appointment date, maybe in 2 or 3 days time or a week's time, so that the patient can come back with further questions, further clarifications, and if they are in distress, be available to them, at all times. So in conclusion, bad news is always bad news, however well it is said. And it is an art. Breaking bad news is science as well as an art. And communication is a very important skill. Poor communication leads to detrimental outcomes and poor decision making in end of life. Barriers can be overcome by proper training, and communication skills can be taught. Communication skills can be learned. It is up to us to put in that effort to learn how to do it. It's like surgery, right? The more you do it, the more defter you become, right? And if if you don't do it right, the damage is irrevocable. And one of the most difficult thing is not saying the wrong thing is often more difficult than saying the right thing. That is something that you have to remember. So be very mindful of what you do when you have these conversations, right? Thank you so much. I think I've just finished on time.
Okay, then I think now we can open for questions. Dr. Sheila had a question. Dr. Sheila?
Yes.
Yes. Ma'am, I want to ask, when the patient is not having any illness and he's just because of old age and he's declining gradually, how do you deal with those patients, ma'am, when they stop eating, because of age, and we get a lot of home visits for those patients also? What do you say to the family about this, that or the patient?
So one of the trajectory of dying is also that, isn't it? When the patient slowly stops eating, starts withdrawing from the surrounding, you've seen the trajectory of dying, the 5 trajectories of death. Are you aware?
No, ma'am.
Okay. End of life care is not done, no?
No,
No,
ma'am.
it's not.
Okay. So maybe at that point, you will know of what happens, right? One of the trajectories, sudden death. One has a waterfall trajectory of cancer. Then there is a looping trajectory where patients get admitted, get well, get admitted, get well, and finally end of life. That happens in organ failure. And one is frailty. They become old, slowly cognitive impairment sets in, functional impairments come in, and slowly they proceed towards the death and dying stage, right? So at that point, so that's also one of the trajectories of death, which is a normal way to go actually. So being able to identify this, and if you are able to identify it, you communicate it to the family using the spikes protocol.
Okay.
You can use the same thing with the family members as well, isn't it?
Yeah, right. So the same thing can be sent to the patient also, or the frailty regarding that he made it.
By the time they are 86, 87, 90, they are prepared that they are in that trajectory, isn't it?
Yeah,
Right?
right.
So at that point, having this conversation, even if death is not imminent, they are preparing, isn't it? Like my father is 86, right? He's already written a will. He has spoken to me about how his last rites have to be conducted. He has spoken about a lot of things, right? He's a hale and healthy man. He's walking around very independent, traveling, doing his own stuff. But still, by the time you reach that age, you are sort of preparing yourself. He lost his brother last year, elder brother last year. So he sort of prepared himself for that end of life event. You don't know when it will occur. So patients are prepared. So it's much more easier talking to them rather than waiting for an illness to come.
Okay. Okay, ma'am. Thank you.
Noble?
Dr. Shah, we have shared the trajectory of dying in the WhatsApp group for the staff students. So we can have as look at it. So shall we go on with the questions, ma'am? Dr. Noble has raised his hand.
Yeah, madam, I have another question. I had a patient with advanced carcinoma lung. He was metastatic disease and he was nearing his last days. So we started him on palliative chemotherapy just to suppress the symptoms. So my question is that I had a situation like this. The bystanders didn't want me to tell the prognosis to the patient. They said that they wanted to reveal the prognosis by themselves. They said that the patient will like when I tell him his prognosis. They said that they will go home and slowly educate him about the prognosis and all that. So how should I respond in this situation? Should I insist on explaining the prognosis to the patient, or should I let the bystanders do it? How should I proceed?
The best way for you to do is to let the family handle that situation if they are confident enough on handling. See, even when I do breaking the collusion, I prefer for the family member to tell rather than they're sitting in front of me, the caregiver and the patient. So I tell him, would you like to share what the doctor has told you with your wife or husband or father or mother? And I'm there to facilitate it, right? But I sit there and make the family member tell, because remember, you are an outsider. You have healthcare knowledge. You're the doctor, right? You are an expert in healthcare. But the patient and the family member are expert in themselves and their family dynamics, right? So
Yes.
they can paste the information in a right manner with their loved one because they know them very well. You don't know them as well, isn't it? Right? So that is the best way to do breaking bad news. I often prefer to be the facilitator, sitting and watching it happen. And if anything, misconceptions are there on the relative side, I also come to know and I correct it. They are breaking the bad news, right? So it's all, if the family members are willing to do it, nothing like it. But empower them on how to do it and how to handle it. Sometimes when the patient becomes very distressed, they tell lies at that point in time. They backtrack. That shouldn't happen. So empower the caregiver to do it right. Explain to them what can happen when it is being told, how upsetting it can be, and how to handle the emotion. Empower them and offer them that let me be present. You can do it in front of me, so that if there is any fallout, I am there to help you deal with it.
Okay, madam. Okay. Thank you.
Ma'am,
Yes.
can you repeat once again about the friend approach? Friends approach.
Friends approach. Friends approach is one is okay. Let me share that slide then.
Yes, ma'am. That will be fine.
Yeah. Acknowledging the feelings, finding out the reasons for collusion, then identifying with the family member about their intention and explaining what happens if you escape from this. Then the pros and cons of being silent. What will happen now, right? Then discuss about what will happen in the future when things deteriorate, what damage it is going to cause. And finally, stabilize the family dynamics and negotiate a contract of when and how they are going to break the collusion. That clear?
Thank you, ma'am.
Ma'am, for the breaking bad news, if the relatives are not, they don't feel confident enough and tell us you do it, so we can we like if they're not ready to do it, can we do and with them in around?
Yes, yes, of course. Hi, Divya.
Hi, ma'am.
Yeah, of course we can do it. We can do it, of course.
Ma'am, let's move on to the case discussion. I think.
Yeah, sure.
May I request Madam Dr. Jogi to present?
Slides.
Ma'am, you have the slides.
Yeah. Hello, everyone. I'm Dr. Jyoti Vaishnav. I'm an ENT consultant in Vadodara, Gujarat. Now, here is a 62 years old female patient having signet cell poorly differentiated adenocarcinoma of body of stomach who is on chemotherapy, a float regimen. She also has type 2 diabetes mellitus and mild hypertension, and she presented with acute gastroenteritis, moderate dehydration, and mild renal impairment to our hospital. And our hospital is a common hospital of physicians and ENT, and this patient is of my husband's patient. Next slide, please. Can we move to next slide? Yeah. The presenting complaint when patient came to us second time, she had acute watery stools, 12 to 13 episodes since one day. There was acute intermittent low-grade fever with vomiting 3 to 4 times since one day. There was abdominal colic pain, generalized weakness. She was not able to walk, feeling giddy, increasing anorexia, and there was excruciating backache since last 15 days. The history of illness, if we see, the first time this patient came to our hospital in physician's OPD in October 2023 with complaint of chronic daily abdominal fullness and heaviness after meals with increasing anorexia for last 45 to 50 days. On ultrasonography, ascites was detected. Ascites tapping was done and approximately 3.5 liter hemorrhagic fluid was drained. The cytology of the fluid was reported as highly suspicious of malignant fluid, but no malignant cells were detected. The CT scan of GIT, surprisingly, did not reveal any GIT pathology. The PET scan, which was done after that, on 26th October, showed metabolically active diffuse circumferential wall thickening in stomach, extending from GE junction up to the antrum of the stomach, with enlarged pericardiac nodes along the lesser curvature and greater curvature, along the common hepatic and splenic arteries, retrocaval, aortic cable, and para-aortic nodes. Upper GI endoscopy was done on 28th of October, which revealed big circumferential growth in stomach, and biopsy from the growth revealed signet cell poorly differentiated adenocarcinoma. Then the chemoport placement was done on 20th November. And then the trial chemotherapy was planned. The float regimen was planned that time. Next slide, please. The family history, the patient's husband was diagnosed with stomach malignancy 1 year back. He was started with chemotherapy and had succumbed after 3 cycles of chemotherapy. Now on examination, when patient came to us second time, there was mild dehydration. The vital data showed temperature 97.8 Fahrenheit, pulse 130 per minute, respiratory rate 20 per minute. The blood pressure was 96 by 60 millimeter of mercury, and SpO2 was 96% on air. Clinical finding: respiratory system, cardiovascular, and CNS system with higher functions were normal. Per abdomen, it was soft. There was no palpable organomegaly. Investigations were done, like ECG was showing sinus tachycardia. RBS was little high. It was 320 milligram per DL. Hemoglobin was 13.7. Total count 2,800. Differential count 75, 21, 3, 1. Platelets were 12,500 and ESR was 68. Serum creatinine was 2.4. Serum sodium 135 milliequivalent per liter. Serum potassium was 5.1 milliequivalent per liter. The treatment given when she was hospitalized, IV fluids were given. Injection methicobal 1500 microgram in 100 cc NS. Injection cifoporazone and salbectam 2 gram in 100 cc NS, IV 8 hourly. Injection ranitidine 50 milligram IV 8 hourly. injection ondansetron 4 milligram IV 8 hourly, injection dexamethasone 8 milligram IV state was given, capsule ridotil, that is racecadotril, was given 1 TDS, tablet Hyoscimix S given 1 TDS, tablet Neutrolin B plus TDS, tablet Epitril 0.5 milligram at bedtime, and the tablet Ridol were given 2 state. If we see the psychological aspect of this patient, this is a widow female patient in her old age, having basic education till 12th standard. She is a housewife living with her only son, who is working in a private company. She has also one daughter who is married. Patient has lost her husband 1 year back in similar malignancy after 3 cycles of chemotherapy. This has given a big impact on her mind. At the back of her mind, she has a fear of failure of the treatment modality of CS stomach. Her husband was working with municipal corporation. So she has medical reimbursement facility at some defined hospital of city as a spouse of ex-employee of municipal corporation. But she's not happy to go to this multi-speciality setup. She's being admitted in ICU here and then after the diagnosis, where she has a feeling of being left out and has developed a phobia of ICU setup. Patient was in denial mode during her first visit for any investigation or treatment. She was having lots of anxiety to face the reality. After counseling, she got convinced for minimum invasive procedures. Now, on suspicion of advanced stage malignancy on PET, she was made convinced for upper GI endoscopy. When she was informed about her diagnosis, after making her son convinced to do so, it seemed she already had the hint of the graveness of her diagnosis. Her immediate response was not to go for any further treatment. Now, on counseling, she got convinced to go for trial chemotherapy. When she came after her first cycle of chemotherapy, she apparently looked very much depressed and seemed to be very suspicious about the outcome of her treatment. On counseling, she is now undergoing further cycles of chemotherapy, which shows her positive attitude to the present situation. The medication at present, she is off the medication of hypertension and diabetes mellitus due to recurrent hypertension and hypoglycemia after discharge. At present, she is on symptomatic medicines in between the 2 cycles of chemotherapy, and she is taking multivitamin regularly. The main concern of the patient, her main concern is the suspicion of the success of the treatment while going through the physical and psychological suffering during chemotherapy. She has immense apprehension about getting admitted in ICU. She is very much anxious about the lack of compassion and patience, which she frequently encounters amongst her caregivers in the ICU, as he has to face significant challenges in communication. So financially, she is not fully dependent on her son as far as medical reimbursement is concerned. She cannot go to the doctor and to the hospital of her choice, as those setups are not listed on the medical corporation list, municipal corporation list. Now she seems to be losing her spiritual faith with her last few years' experiences. Summarizing this case, we have a 62-year-old widow female patient who is a housewife suffering from advanced stage of CS stomach, started on trial chemotherapy. She has lost her husband 1 year back after 3 cycles of chemotherapy given for similar pathology in stomach, which has left a grave impact on her mind. And due to this reason, her son was not ready to disclose the diagnosis to her mother. Now, on close counseling of his son, he got agreed to let her know about her diagnosis. Now, on the disclosure of the diagnosis to her by my husband, who is her treating physician, with whom she shares a good rapport, she accepted the reality well, but initially she was not ready at all to undergo any further management due to her suspicion of the outcome of CT. Financially, she is partially dependent on her son for medical reimbursement. She has got immense apprehension to get admitted in ICU. Now, in spite of her anxiety, apprehension, and increasing physical morbidity, she has still chosen to go for further cycles of chemotherapy, now which shows her mental strength and positive attitude towards her future after counseling. Now, point of discussion here, we can have like, is she a right candidate for palliative care? Is it a right decision to disclose the diagnosis and prognosis of this disease to her? Are we able to disclose in clear words the outcome of such chemotherapy in her case? Is she a right candidate for curative or palliative chemotherapy? How can we alleviate her apprehension to get admitted in ICU setup? How can we uplift the spiritual status of her mind? Thank you. The case is open for discussion.
Thank you, Doctor. I think with the perspective of the session today, we can little modify the discussion. So, of course, is she the right candidate for palliative care?
Of course, it's a,
Yes.
to me, yes.
Anyone has any opposition for that?
No, is correct candidate for the palliative care.
Thank you. Thank you all. Then let's move more about
Somebody
this.
has written no.
I think there is Dr. Vinita.
Sir, I said no for any objection. She is
Okay.
fit for palliative.
Okay, so the question, main thing that is the right decision to disclose the diagnosis and prognosis of the disease to her?
I think everybody is answering yes.
So what would have been done if the son has objected to that? Such a situation has arisen. That would be the point of discussion that we can have after the session.
Somebody has written friends approach counseling depends. It should be a shared decision. Absolutely. Communicate with the son. Yes.
Would anyone like to describe more about what you want to communicate, how to counsel them?
Preparation for breaking bad news. Yes.
We can communicate with the son we can discuss about the pros and cons of revealing the truth to the patient.
So the son might have initially, I think he initially objected because he had an initial experience. I think it was father, right? So how did you get this happen, man? Dr. Jyoti, you can explain how it happened.
Actually, it all depends, like, the family was very close to the physician, my husband, and they really rely upon him. And that was the main point, he could make him agree. He could explain him that it is really in benefit of the patient, in benefit of her mother, that we should we should make it very clear to mother. And he told him that she is smart enough to understand the diagnosis, even if we'll not tell her. Because she has also experienced the thing with her husband. So she must be very clear, but it is very good to tell her frankly, so that there won't be any mask between the son and mother. They will be more natural in their in their communication. So it was not very difficult, in fact, to explain the son. And after he got convinced, we just sat with the mother, and
Ma'am, you're muted.
she was Yeah, and it was very obvious that she was aware about the thing. The only thing that she wanted someone to tell her about the diagnosis. And that is the reason she initially, she was not ready to go for any investigation or any treatment. Even after the diagnosis, she was not ready for the treatment because she had the same thing in her mind that, it's not going to help her. But then she was explained that each pathology may be different and each chemotherapy will be different, and she may respond positively. So we must have a trial chemotherapy at least for 3 to 4 cycles, and then we can reevaluate the thing.
Handing over to you, Dr. Seema, ma'am.
Yeah. So I just want to share one slide. Can I do that?
Sure,
Yeah.
ma'am. We'll stop this.
Okay. Continue. So when we talk about, right, 1 minute, when we talk about what she was saying, right, when the family has the relationship with the doctor has, sometimes influences the decision making, right? So the doctor-patient relationship, when we look at, it has 4 models, right? One is the paternalistic model, right? Where, previously it was more of I decide for you, right? I will take the decision. You just listen to what I have to say, right? The second model, when it became more consumeristic, it's about informative model. I'm going to give you all informations about the disease, the statistics, etc. You decide and come back to me what you want, right? That is I give you the facts and you decide. As a patient, you decide. Okay. But from there, it moved on to a more deliberative model, right? It is, in addition to giving you the facts, if I was in your position, I would do. If my father was in this position or my mother was in this position, I would do this. That is the deliberative model. We have evolved from that into an interpretative model, which is what we look at in palliative care. I give you the facts. I tell you my preferences and I help you find your preferences. What is it do you want? After understanding the facts, right? What is it that you want? Do you still want to go ahead with treatment or not? Right? So when it is a shared decision making, right? Especially in cases like this, where there is advanced disease, right? And the palliative chemotherapy may work, may not work, or even if it works, the decision depends upon the patient. After explaining the pros and cons to the patient, you help her find what she wants to do, right? Maybe at the age of 86, I'm not talking about this patient. The patient may say, I don't want, even if there is cure, I may not want to go ahead with the chemotherapy because I don't want to suffer. I know I'm 86, I've finished my life's goals, whatever it is. I know death is imminent, right? At this age, I don't want to go ahead with chemotherapy. And then, even if it is curable, right? And then you have this ethical dilemma of, do we respect the patient autonomy, or we think this patient can be cured, we can control the disease? Do we push through for them taking treatment? So when there is a conflict between autonomy and beneficence, what wins? Autonomy, patient autonomy, provided it is an informed choice, understanding the pros and cons, patient autonomy wins. So when you said, right, sometimes we play a big role in what decisions they take. Our role is in ensuring that the decision that they take is based on their preferences after understanding the pros and cons. Right? Sometimes if you force them to take palliative chemotherapy, maybe that individual does not want it, right? The chances of becoming more depressed, anxious, the quality of life goes down, right? So maybe having these conversations, they might, when you tell them like your preferences, they may accept it, okay? And it's important to review at every point in time, do they want to go ahead or not? And if she doesn't want to, respect her choices, provided she understands where she is going. That by not taking the chemotherapy, death is imminent. She needs to understand that. And then she says, I'm willing to walk that path. Right? Then probably that is I prefer the interpretative one. I prefer educating. I prefer, sometimes I use the deliberative approach when they can't make decisions. If it was my person in that space, I would have made this decision. But the process of making this decision has this pros and cons. Right? Yeah, so that is the models of communication, doctor-patient communication, which are there. Previously, it was paternalistic.
In fact, what ma'am you said about the deliberative approach, the same thing actually was discussed. My mother-in-law had the same pathology. So my husband told the same thing, that my mother had the same thing. And, she preferred to go for the chemotherapy. So actually that was the autonomy part, because she was quite, like she was more than 80, but she wanted, we were aware that there is no role of chemotherapy, but just because she wanted to go for that, we had given that. But then though we didn't clear cut told the patient, this patient, we just said that, we had done this, it's up to you if you want to go for the session or not.
I think somebody, Juliet, has raised their hands. You can.
Okay, thank you. As you said that we have to inform the patient of the details of the illness, but sometimes there are patients that do not want us tell them those details. They tell us that just do as you wish, what is best for me. So in such scenarios, what are we expected to do?
So based on the best interest of the patient, about what you think, then your medical decision making comes into the picture. As keeping the best interest of the patient, is this patient a candidate for further chemotherapy or not? Okay, so then the decision making falls on you, which is like, what, given your knowledge about that medical illness, about prognostication, what is the approach that you would take? You become the surrogate decision maker, for the patient then.
Okay, thank you, ma'am.
I think more of these doubts would be more clear after the session on ethics.
Yes.
Yes, we still have the session is planned for next time. So anything else to be discussed? Anyone has any doubt or anything?
I think we are run out of time, 6:30.
Okay, then, ma'am, shall we wind up?
Yes. Yeah.
Once again, thank you, ma'am, for the wonderful session. Thank you, everyone, for the interaction. And happy weekend, everyone. See you for the next session. Thank you, ma'am. Thank you, everyone. Have a good day.
Thank you.